Good afternoon, everyone. This is Dr. Mark Rudolph, Sound's Chief Experience Officer. Thanks very much for joining us as we continue the COVID-19 clinical webinar series. As always, we will have Q&A at the end of the presentation, so please feel free to submit questions throughout the presentation in the chat box at the bottom of the control panel. We are recording this, and so we'll send an email out with a link to the recording afterwards. We'll also include any other resources and links that we mentioned during the presentation. And at this time, I would like to turn it over to Dr. John Berkmeyer, our Chief Clinical Officer, for a couple of comments. John?
Thank you, Mark, and good afternoon, everybody. This is John Berkmeyer. I'm the Chief Clinical Officer at Sound. Thank you for taking time out of your busy clinical lives to join this week's COVID-19 clinical webinar. I think the theme of this week and today's webinar is one of optimism. Don't get me wrong, we and more importantly, our patients continue to trod through the COVID pandemic. We're now approximately 8 going on 9 weeks since the pandemic came on in earnest. We're still admitting approximately 400 COVID patients per day. So if the curve is bending, it's bending very, very slowly, both across the nation and at Sound. Why I said the theme is optimism is that I think we, from a clinical perspective, have settled into at least this phase of the new normal. We are in substantially better shape than we were a few weeks ago with regards to PPE for our providers. While we continue to have patients that either get exposed and go have providers that get exposed and go on quarantine, and a smaller number that have gotten infected by an large. We currently have had no one that has gotten significantly ill as a result. And finally, the theme is optimism in that, by many indicators, we're starting to turn the corner. Outside of healthcare, reopening is occurring in a growing number of states, and reopening is occurring within our hospitals as well. Elective surgery is resuming as we look solely at our own hospital medicine volumes. As you'll see in a minute, they're slowly but surely coming up. And while we have a ways to go, we are becoming increasingly optimistic that some of the economic hangover effects of the COVID pandemic will be short-lived. And then finally, I think we're very optimistic in that we're seeing is that we continue to see a significant degree of resilience among our clinical community, and continue to have daily reports of selflessness and heroism from the front line. So thank you for all that you're doing. So today, the theme will be providing you an update on where we are with regards to Sound's clinical practices. We'll talk about what reopening means from a Sound in a clinical perspective, and Sergio and Greg and Mark will provide new information with regards to updates on both clinical guidance and new initiatives with regards to clinician well-being. So let me introduce our speakers for the day. Many of you have met them before. Dr. Greg Johnson, the Chief Medical Officer for Sound Hospital Medicine. Dr. Sergio Zanotti, our CMO for Sound Critical Care. And while he won't be here today, in spirit is Dr. Nate Ruck, CMO for Sound EM. So thank you guys, and thank you, Mark.
Thanks, John. Appreciate your providing that background and giving everybody an idea of what the agenda is that we'll walk through today. So first, our typical Sound update and reinforcing what John shared with respect to what's happening, this is obviously data that is coming from Soundmetrics. You can see the dates. So this is really starting from March, when we really first had access via the information that you're inputting in Sound Connect and migrating into Soundmetrics, but giving us a sense of the total active patients that we are, and active patients include patients that we're still screening, and then a sense of the total number of admissions. And again, this is pretty consistent with what John stated, that we're still seeing a significant number of newly admitted cases that have a level of suspicion. However, it is tailing off, but tailing off slowly. The admission trends in a little bit more detail, and really getting down at the bottom orange line indicating the total number of confirmed cases. Again, some of that is going to be contingent upon testing and testing results and the capabilities that occur at individual sites. That number does appear to be down, but obviously we still have a significant number of cases and still a significant number of people that are being screened. So to John's point, we know that there is some variability. The sawtooth pattern that you see there is somewhat indicative of what we're seeing occur on weekends, but you know, there is indication that things are slowing, and that is part of the reason why we'll be discussing issues like reopening and what that's going to look like for a number of our hospitals. So we'll just get into that with respect to reopening. And the first piece is that we wanted to provide some updates with respect to the CDC's ever-evolving criteria for returning to work. As John mentioned earlier, and as we've been very fortunate as an organization to see, we've had people quarantined. The quarantine criteria and now the return to work criteria have evolved, but these reinforce the two primary ways that we want, and we are reinforcing to our hospital partners with respect to how people are returning to work. Most of our focus has been on the symptom-based strategy and focusing on, you know, for individuals that had been symptomatic or had confirmed disease, that there was at least 72 hours from actual recovery without additional medications and with symptoms, and knowing that they've had at least 10 days since their symptoms first appeared. Again, we've really adopted the symptom-based strategy because testing is so variable and because of concerns about the false negative rates that have been associated with the testing. The test-based strategy, you can read that's there before you. Negative results, really what the CDC has recommended is if your hospital has focused on a testing-based strategy, knowing that it's got to be from 2 consecutive specimens collected greater than 24 hours from nasopharyngeal swabs. Again, our focus has primarily been on the symptom-based strategy because it is a lot more straightforward, especially knowing that testing timelines are highly variable according to where you live. For the asymptomatic people, the CDC is now focused again on a time-based strategy. Again, 10 days passed since the first positive test, assuming that they've had a test, or since they've developed symptoms. If somebody develops symptoms, and again, this is extracted directly from the CDC website, then the issue, if you develop symptoms and a confirmed test, then you would flip over into what was described previously. And then the test-based is, again, just 2 negative tests, really are a good reason for people to be back at work. But understanding that even a positive test doesn't mean that you're infectious. That from prior webinars should have been underscored that most of the studies that exist out there are underscoring the fact that most people are likely symptomatic, they are infectious when they first develop symptoms. and that the testing doesn't necessarily correlate with being infectious. It is, however, a strategy that some of our hospitals and obviously the CDC are recommending, depending on which they have available. Now, as far as reopening, the CDC has provided an update, and this is in conjunction with what is also coming from the White House, and it outlines 3 very specific phases about what reopening looks like. Phase 4, this is going to be very specific for hospitals and health systems, and a bit about long-term care facilities. Phase 1, where I think the vast majority of hospitals live, is very specific about elective surgeries and making sure that there are clinical guidelines with respect to screening patients. Phase 2 is that it's limited visitation, but again, surgeries can continue, and they are looking for more of the elective items that would come through hospitals. And then phase 3 is really effectively back to normal. These are, again, per the White House and CDC recommendations, and I will refer to you all to access the report that the CDC has published. It's about 60 pages, and so prepare yourself for an extended read, but it at least provides some guidance as to what the separate phases mean. This may be a little challenging to read, but the part that John wanted to discuss in terms of optimism was really understanding that in conjunction with the CDC, the White House has really outlined some very specific gating criteria for hospitals to enter specific phases. So it's the reason why we define the phases up front, and then you can see to the left the gating criteria, all of which are contingent on measurable improvements, measurable reductions in the number of cases, whether it's in the emergency department, whether it's a COVID-like illness or flu-like illness, testing, and then the availability of beds. Part of the reason why we want to make sure that this is in your hands is we are very aware that, first off, we are likely the primary admitters for most of our hospitals. As they are opening and looking for elective cases, you need to be informed and be using the data that you have from both what you have in the community as well as what you can access in Sound Metrics to be able to help to assess where are we, and is this data, the data that we have, also consistent in terms of helping to think about where your individual hospital is with respect to the different phases. Doesn't mean that you're the one that's making the ultimate decisions, but the part that is most reinforced from the CDC is making sure that there is consistent data that is being reviewed and a consistent source of data that's being reviewed in order to make a determination of when you move from phase 1 to phase 2. The other piece for each of these gating criteria is also understanding that essentially you have to be within a 2-week, 14-day period in one phase before you move into the next. I think that's something that we want to make sure that everybody's considering, because the reasoning, I believe, that comes through this really is focused on, okay, if something occurs in a community, when do you back off, or when do you essentially resume sort of the emergency situations that we were in before? So I think how the CDC has outlined it at least provides a framework for how your hospitals are considering reopening, when they're considering the cases that are coming through, and at least provides you the opportunity to review the same information that our hospitals and hospital partners are going through in order to make determinations of where to go. I would spend a little time looking at the being able to treat patients without crisis care, and some of that being contingent on the number of ICU beds, the staffing, and obviously an adequate supply of PPE. For other reopening references, before we shift into the clinical discussions, want to make sure that that everybody has access to, and you can click on the hyperlinks when we make this available. There are two articles, the first of which is from JAMA about reopening and the type of testing and screening that should be available, as well as the full CDC report. For those who like to read this information, there is very specific information that's outlined that outlines not only hospitals reopening, the long-term care facilities, for those who are interested, restaurants and bars, as well as mass transit and other areas that the general population accesses. With that, I'm going to turn things over to Sergio, and he can give our clinical update.
Thanks, Greg, and thanks, John, also for the words at the introduction. Today, for the clinical guidance portion, we're going to focus specifically on acute kidney injury within COVID-19, and then we'll have time at the end for Q&A if there's other clinical topics that are of interest. There's always, I think, a lot of studies being released and commentaries based on what's happening with the press that might be of interest for the team, so we can talk about that later. But as we talk about acute kidney injury, I think that two things are important to emphasize regarding acute kidney injury in all hospitalized patients. First is that we've struggled over the years with having uniform criteria and diagnosis. There are several guidelines that have been published. This is from the Kidney Disease Improvement for Global Outcomes Initiative, the KDIGO, which have defined acute kidney injury into 3 stages based on creatinine and urine output criteria. As you can see, I mean, that is, I think, a very useful way of thinking about it in hospitalized patients. What I think is also very important, and I think it's very relevant to all of our practices, is the recognition that either as a marker of disease or an independent risk factor, the presence of acute kidney injury does confer patients a worse outcome and a higher risk of dying in the hospital. And as you can see, that is also dependent on the severity of the kidney injury as measured by the stage 1, 2, and 3. So this is something that we see in all hospitalized patients on the floors in the ICU. So let's talk a little bit about AKI and COVID specifically. And what you can see here is this is basically just a diagram that shows you from the onset of symptoms what usually happens with patients. Usually they present to the hospital around days 7 to 10 with the majority of them with increased shortness of breath. Of all the patients that have been tested positive for COVID, we believe that around 15% of these patients end up having a severe illness as defined of needing hospitalization, and of the total number, 5% of the symptomatic patients actually end up in the ICU. What we've learned so far about the association of acute kidney injury and these patients coming into the hospital is that over 40% of hospitalized patients with COVID-19 have abnormal proteinuria. If you look at their urine analysis, around 30% or a third of the patients who come to the ICU will develop acute kidney injury, and around 20% of the patients with COVID-19, so 1 in 5 that get admitted to the ICU, will be placed on renal replacement therapy. And this usually happens around day 14 or 15 since the onset of symptoms, which is usually a couple of days after they get intubated or get admitted to the ICU. Next slide. This is actually a nice summary of a large cohort study that was published in Kidney International a couple of days ago. This was a retrospective cohort that included 13 hospitals in New York. All patients were SARS-CoV-2 positive, a total of 5,449 patients with a median age of 64. And this is within the span of a little bit more of a month, so March 1st to April 5th. And what you can see is that the proportion of patients with AKI was almost 40%, so almost 2,000 of these patients who were hospitalized had AKI as per KDIGO definitions. You can see the distribution. Stage 1, the majority with 47, stage 2, 22, and then a third of stage 3, which are probably the sicker patients. And you can see also that the probability of them being diagnosed with AKI was really around the admission to the related to the initiation of mechanical ventilation in the patients who were sicker. In terms of independent risk factors for AKI, older age, which we've seen is a clear marker of more severe disease, black race, hypertension, diabetes mellitus, cardiovascular disease, vasopressor use, and need for ventilation were all independent risk factors for AKI. And I think it just speaks to some of the age-related implications. Probably there are significant disparity issues that are driving some of the higher incidence in African American and in other minorities, but also the comorbid diseases that are commonly associated with acute kidney injury in non-COVID patients. And finally, from an ICU perspective, we all know that patients who have hemodynamic instability and require vasopressors, or who have acute respiratory failure and require mechanical ventilation, are usually at a much higher risk of having acute kidney injury. Finally, they talked about the disposition of these patients. So a significant amount of these AKI patients, 40%, still hospitalized. A fourth of them, or 26%, were discharged, and almost a third of them died. So obviously these were very sick patients. This study concluded that AKI occurs frequently among patients with COVID-19. It occurs early and in temporal association with respiratory failure, so it's the time that these patients are developing need for respiratory support. And AKI, where independently or as a marker of severity, is associated with poor prognosis in these patients, which is something that I think a lot of our clinicians have seen. So let's start talking a little bit more about pathophysiology in COVID-19. Obviously, still a lot that we're learning. Next slide, please. The cause of acute kidney injury in COVID-19 is still evolving. It likely is multifactorial. There are clearly predisposing factors that are commonly present in these COVID-19 patients, such as sepsis. A lot of these patients, and this is something that we'll talk about in treatment, when they present to the hospital, have had a week of fever, increased respiratory rate, sometimes GI symptoms, very likely to be intravascular volume depleted, so have hypovolemia. We are using a lot of drugs that might be nephrotoxins. This is something that's very important as well. And then there might be some other iatrogenic factors like aggressive diuresis, trying to improve oxygenation, and some regimens that early on, I think, really tried to diurese these patients from the get-go, when maybe at the initial phase, they probably would have benefited from some fluid, and we'll talk a little bit about that. From a cardio-renal perspective, there are two interesting dynamics here. There are some studies that are associating right ventricular dilatation with worse outcomes in these patients. Obviously, right ventricular failure associated with severe respiratory disease, acute respiratory disease, can cause venous congestion, renal congestion, and can lead to one form of cardiorenal syndrome. So definitely we're seeing these right ventricular issues in biopsies as a risk marker and can be a driver of AKI in the sick patients. On the other hand, we've also seen left ventricular failure, and that by a function of decreasing cardiac output and causing renal hypoperfusion can be another driver of acute kidney injury. And finally, with all the talk of the predilection of the SARS-CoV-2 virus on certain ACE2 receptors, which are very frequent in the endothelium in the lung, but also in the kidney, could there be some direct effects of the virus on the kidney? That's something that we're exploring. Clearly been identified in some virus particles in the kidney have been identified in autopsy series, and also the whole idea of the immunomodulation or cytokine response related to SARS-CoV-2 can also be a driver of acute kidney injury. So clearly a lot of reasons why these patients might develop acute kidney injury. So let's talk about what are the things that we can do actually for treatment. This is general management guidelines that apply from the KDIGO for all acute kidney injury in hospitalized patients. Obviously, paying special attention to nephrotoxic agents, dosing of antibiotics as the GFR goes down, I think is very important. Ensure adequate volume status. And this is very interesting because I think that we've seen a little bit of a pendular swing here. I think that we are concerned with the amount of respiratory failure, the amount of non-cardiogenic pulmonary edema and ARDS in these patients. So clearly a lot of the guidance has been to try to keep these patients dry. Some people have taken that to the extreme of very aggressive diuresis as soon as patients got diagnosed with COVID-19. I think that what we're trying to find is more of a balance, recognizing that clinically, patients who've been at home for a week with fevers, high fevers, increased respiratory rates, and maybe plus minus GI symptoms, when they arrive to the hospital, are very likely to be intravascular volume depleted. So I think that early on in these patients, judicious use of intravascular volume repletion is going to be very important. As these patients progress and move into the hospital, then to the ICU, clearly as their respiratory failure becomes more prevalent, keeping them euvolemic or a little bit on the dry side might be the way to go. But I think that we have to consider very closely what is happening with the renal function as part of this equation as well. I think that considering functional hemodynamic monitoring with the use of dynamic parameters, especially for those patients who are getting sicker, is going to be very important. Following serum creatinine and urine output in all these patients, and then obviously just good care, such avoid of hyperglycemia and critical illness or severe disease, and considering the alternatives to radio contrast procedures when we don't need them, I think is going to be very, very important. And as these patients get worse, I think that obviously evaluating their kidneys, making sure we're not missing anything, and then the early consideration of renal replacement therapy, which is usually going to happen in the ICU, is also going to be very important. They in generally have avoided for acute kidney injury the use of subclavian catheters based on the presumption that using the subclavian for these patients is more likely to eventually cause stenosis of the subclavian veins that ultimately might have implications for long-term dialysis access. Now, another interesting point with these patients is that probably the preferred route of access for those patients who will need renal replacement therapy with COVID is using the right internal jugular, mostly because that's the best place for securing the catheter if we're going to prone the patients. And considering the experience that we've had, and clearly as a clinician, I can speak of last week, I've had several patients who required renal replacement therapy who were also prone. And in all these patients, I mean, the preferred route for the temporary dialysis catheter was the right internal jugular. The other thing I want to just share here in terms of drug considerations for COVID-19 patients who are developing acute kidney injury. So as all of you know from our previous webinar, remdesivir has received an emergency approval use authorization from the FDA. There are trials that are ongoing. A lot of the trials have excluded patients with severe acute kidney injury and RRT, and this is related to the renal excretion of the drug. This is not an exclusion for compassionate use, but I think that we have to figure out how to track this in patients who get remdesivir on the compassionate or the emergency authorization usage form outside of the context of a clinical trial. Favipiravir is a drug that has been proposed in Japan, is being utilized in some research studies here in the United States, and it's another broad-spectrum antiviral. And again, here, this is mostly excreted through other mechanisms, so there's really no dose adjustment, and it can be utilized in renal failure. You've heard a lot about hydroxychloroquine a couple weeks ago, and again in the press, I mean, yesterday for many reasons. The studies so far have really not shown that hydroxychloroquine or chloroquine are really useful or found to be useful in hospitalized patients. 30% of these drugs are excreted by the kidney. So in patients with acute kidney injury who are on these drugs, the levels are going to be increased, and I think it calls for more vigilance regarding monitoring of the QT, although my feeling is that there should be less and less patients that are hospitalized that are getting hydroxychloroquine or chloroquine for COVID-19. In terms of anti-inflammatory medications, and this was initially used off-label in a lot of places, I think now people are more restrictive in terms of trying to use drugs as IL-6 inhibitors and other anti-inflammatory modulators within the context of clinical trials. But again, these are not usually affected by the kidney. They're much smaller than what we remove with renal replacement therapy. So there's really no adjustment that needs to be made for these drugs in patients with acute kidney injury. And finally, we'll talk a little bit about anticoagulation, but clearly in those patients who are placed on renal replacement therapy, especially CVVH, anticoagulation has become a big issue because of the frequent clotting of these devices. And I think that it might be an indication for full anticoagulation, as you'll see in a lot of these patients. So these are some of the general guidelines that I think we should be thinking about when we're managing these patients. The next slide really speaks about how do we approach renal replacement therapy, which is something that in some of our ICUs has become very prevalent, as we've described, with these large numbers in ICUs and a high percent of these patients requiring renal replacement therapy. A lot of these patients have been placed on renal replacement therapy in the ICU. In terms of indications, I think they're similar to non-COVID patients: oliguria with refractory hypervolemia, hyperkalemia, severe acidosis, and progressive azotemia. Some people have proposed that in the presence of the cytokine release syndrome, some ways of extracorporeal removal, such as CVVH, might be recommended. The real evidence there, I think, is still kind of questionable. It's something that has been tried before with hemoabsorption and elimination of endotoxins, but I think in some studies, people might be considering RRT. Also, in those patients who are placed on ECMO, a lot of times RRT is incorporated into the ECMO circuit, and that's something that helps manage the volume of these patients. So you might see that in ICUs where we're doing a lot of ECMO. In terms of preparing for RRT, as I said, these patients will need a vascular access. The preferred site for COVID respiratory patients is right jugular vein, in terms of making sure that we can prone them. If possible, having a separate line for RRT and ECMO patients is better, but a lot of times that is not possible. And in those cases, we might utilize the ECMO circuit itself for doing the RRT. In terms of how to prescribe or how to do that, it's obviously something that nephrology will manage. But I think that the most important thing here to understand is that anticoagulation is going to be an issue. Some teams have recommended using rich citrate and the 4% trisodium citrate in these patients. Low molecular weight heparin or ultrafiltrated heparin at full dose anticoagulation, either given systemically or through the CRT circuit, are also needed. And one of the things that we've seen a lot with these patients, especially early on when we were less aggressive with the anticoagulation, was clotting of the RRT, the CVVH filters very frequently. So some people have also increased the prescribed dose of CRT, understanding that some of these patients might be off the CRT machine more frequently. In terms of monitoring and the delivery itself, I mean, obviously making sure that the catheter works, calculating the treatment downtime because of the clotting, I think is going to be very important. Changing the filter frequently, every 24 hours, I think is also very important. And then finally, in terms of monitoring, the usual things that we check, especially when we prone these patients, making sure the catheter is still in place, using, anticoagulation strategies, following the PTT or the anti-10A activity if we can, and making sure that we are following hemodynamics and fluid balance. I think that the transition out of CVVHD is similar to non-COVID patients. As they start recovering their renal function, as their hemodynamics start improving, we usually take them off of that into intermittent dialysis. We really have no data on what is the recovery rate related to COVID with AKI, but so far we've seen that it's no different than other patients with AKI, and that I think it all depends on what the pre-acute illness renal function was, how severe the patient was, but clearly it doesn't mean that all these patients will require long-term dialysis. So those are some of the considerations that I think that we should share regarding AKI within COVID, which has been a very common complication for COVID patients, but also something that we commonly see in our hospitalized patients and ICU patients. So Next slide, please. We want to start by acknowledging clinician well-being, obviously being a very important aspect of what was going on in medicine prior to COVID, that I think has only been exacerbated by the stressors from COVID. Next slide. I think that Greg, Nate, and myself with Mark have been talking a lot about this whole idea of burnout and how it's been impacted by COVID. Clearly, we had a tremendous amount of physician burnout and clinician burnout pre-COVID. We think that COVID will just add additional stressors, and I think it's another opportunity for us to get together and really at a systematic level, try to change things for the better, recognizing that the toll that a lot of changes in our healthcare have imposed on clinicians has already created tremendous amount of burnout. But now with this toll that the number of patients in COVID-19 and all the issues related to the pandemic have put on our clinicians, I think it's even more dire. And these are some of the papers that have been published recently in the New England Journal of Medicine, just addressing this issue and calling for not only, hospitals and clinician leaders, but also for federal agencies and others to really make important changes that can really help us alleviate this. So without further ado, I will introduce Mark Rudolph, who will address some of the issues related to clinician well-being and some of the initiatives that are available through Sound, but also that we're trying to push at a local level. Mark, thank you very much.
Thanks so much, Sergio. As Sergio importantly points out, this issue of clinician well-being is something that obviously predates the COVID-19 pandemic. And, there are, I'm sure, many of you who have struggled with issues relating to burnout, or at least known people who have. And one of the things that really complicates the issue here is that all of us have been programmed to keep our chins up no matter what. And, despite the victories, some of which we've experienced during the COVID pandemic, there's also a lot to be pretty stressed about and frightened about. And so when I think about this picture and I look at people feeling good about this patient, which is fantastic, we've got to celebrate our victories. I also wonder what's behind the masks, what's behind the thumbs up for each of these individuals here. And so the good news is, if you go to the next slide, as everybody has been saying during the course of the pandemic, that we are all in this together. This is a rare occasion where everyone is experiencing, to some extent or another, the same challenges at the same time. You may not have the exact same scenario at your facility, but across the country, all of the economic parameters, all of the parameters that are currently governing the clinical interventions we have, it's the same everywhere you go. And so the great news has been that we've been able to rely on one another. And I think this will continue to be one of the most important ways that we will be able to support one another and come out of this whole pandemic process, to whatever extent we come out of it, stronger, and having addressed things like burnout and the potential for things downstream from the events of the pandemic, like PTSD, et cetera, which I'm sure you've read about in the press. And so one of the things that I want to focus on, and that we're actually going to be focusing on more in the near future, if you go to the next slide, is the ability for all of us to take cues from one another and maybe offer the opportunity to listen and really support one another. And I don't mean that we're going to provide each other mental health expertise. We're simply going to provide each other psychological support. And a week from Friday, Fabienne Moore and I are going to be hosting a webinar titled Coping with COVID, and it's going to focus on how we can support one another using the key principles of something called psychological first aid. Psychological first aid was developed in the mid-2000s to help people that are exposed to very stressful or traumatic events. It doesn't have to be something, some huge scale like 9/11 or taking care of 100 COVID patients. It could really just be the big stressors that we've all been dealing with day in and day out, concerns about infecting our families, concerns about infecting our colleagues, concerns about being able to take care of our patients and even just save their lives. So I encourage you to register and tune in. You'll be getting an email about that in the near future. But really, in the meantime, I'd encourage you, regardless, to listen for opportunities to do some really simple things with your colleagues, which is to empathize, to validate, and to normalize some of the concerns and feelings that all of us are having, and really just open the door to a conversation, taking the time to ask somebody, that sounds really hard. Is that something you'd like to talk about? Whatever way feels comfortable for you. But these are, if ever there were a time for us to lean on one another, these are those times. Next slide. As Sergio mentioned, we do have a number of resources, and hopefully folks have heard about most of these by now. The peer support program, which is internal to Sound, is a number of your colleagues who actually have received training that was based on that psychological first aid that I mentioned. And anybody can call the peer support program and chat with somebody completely confidentially. No records are kept, and you can call this number 24/7. You also can call Sound's Employee Assistance Program, which can help you not only with obtaining counseling sessions if you wanted something like that, but also help with different life issues, financial things. If you had a loved one that needed long-term care in another state and weren't sure what to do about it, you could get help with that sort of thing. And then external to Sound is something called the Physician Support Line, which you may have seen on the web. This is a group of psychiatrists that are volunteering to help anyone. I think it's 8 a.m. to midnight Eastern Standard Time. But this is, again, totally confidential, no records kept, and something that's out there for clinicians. Next slide. I just want to point out Sound's well-being page. This is accessible now via the soundphysicians.com website, so pretty easy to find if you just look under tools, same place you go to get onto Sound Connect or to get on email. You can also access it directly from within Sound Connect. And this is where you can at any time find information about things like the peer support program. You don't have immediate access to it. And I tested this myself, and I was able to find the peer support button 8 out of 10 times. So I thought that was pretty good, pretty easy to navigate here. Next slide. We're going to move on to Q&A. Please feel free to enter questions about any of the resources that I just mentioned, as well as clinical questions that you may have. And at this moment, we actually don't have any questions. So I'm going to ask Sergio or Greg if any of the conversation that we've had since you spoke stimulated a comment that you might like to make.
Well, I just want to also tell our colleagues that the 2 times that Mark did not find the peer support button, we got on a GoToWebinar and I was able to show him where it was. So it's really, I mean, you can get there with help, right, Mark?
Yeah, no, thanks, Sergio. Your support, it meant a lot to me.
No, I think that one of the not a comment, but just, I mean, for the teams, for our colleagues on the call, if you could let us know what are topics that would be of interest for you moving forward. Clearly, every day there's new studies. I think that yesterday, obviously, there was a lot of discussion on TV about the president taking hydrochloroquine and what does that really mean. The reality is that, like I said, the studies in hospitalized patients have really been less than impressive to maybe it can cause harm. But the reality also is that despite a large number of studies being published, none of the studies by themselves are super high quality, randomized, double-blind controlled studies with large numbers. But I think that still the majority of the data that we're seeing does not indicate tremendous value and potential harm in hospitalized patients. There is one large study from Minnesota that has looked at the use of hydrochloroquine as a prophylactic therapy for COVID-19, which is the way the president's taking it, which would also, I think, would be very important for us as healthcare providers on the front lines. That is not completed and it's not out yet, but I think that the results of that study obviously would have, I think, significant implications for frontline providers.
Sergio,
go ahead.
Yes.
Go ahead, Mark.
Oh, there's a question, but Craig, do you want to add something?
No. Go ahead with the question.
Okay. The question has to do with some of the recent news about COVID-19 and the potential for a relationship to Kawasaki disease in children.
Yeah, and I think that obviously not being a pediatrician, that's not my area of expertise, but I do think that the one thing that is evident to me is that a lot of the things that have been described with COVID-19 have occurred with other severe infections. And that might be also with Kawasaki. What we have not seen ever, I think, at least in recent memory, is such a large amount of people who got infected with the same pathogen. So I think that understanding how much this is related to an individual characteristic of a virus versus it's something that might be related to an immune response triggered by an infection, just that the number of infections that we saw was so overwhelming in such a short period of time that we're describing all these things, I think is still unknown. But obviously, the assumption that younger kids or younger patients are not affected at all, obviously is not correct. I mean, kids who have comorbid diseases have had bad outcomes, and there was a great series from kids with COVID-19 who ended up in the ICU, published with lead authors were from Texas Children. Again, those kids can have severe disease, and with this Kawasaki syndrome, I think there seems to be some connection in a small group of young patients. Again, I think that we need to understand more about this, but also remember that we don't even know what the denominator is of the number of young patients who would be positive with COVID-19, because we do believe that there's a big proportion of these patients who are, or these people who are COVID-19 who are asymptomatic. And based on what we've seen, that asymptomatic group might be even larger in young populations. But I think that we'll probably learn more as more data is published.
Thanks, Sergio. Sergio, while we have you, can you just recap the bottom line on remdesivir?
So I think that remdesivir has been approved as an based on an emergency use authorization by the FDA. That's based on safety profiles from the studies, but also that in one study that the FDA conducted that has not, the NIH and FDA, that has not been published, they found a difference in time to recovery. So no impact on mortality, but a difference in time to recovery. So with that, they felt that there's still evidence to keep trying to figure out what the role of remdesivir is. Right now, you can get it through a clinical trial, or you can get it for severely ill patients if your hospital has remdesivir. So the distribution is now managed by the FDA. So different hospitals have received a number of doses, and they may be able to use it in severely ill patients on a compassionate use outside of a clinical trial, but it still requires that you consent the patient, that you inform the family. It requires informed consent, and it requires that you as a clinician provide written information that's available on the FDA. It's actually available on our last webinar, the link to the patient and their family, and that you do report to the FDA any adverse outcomes. Now, you should find out in your hospital if they have remdesivir, because you just can't order it. And if they have it, there has to be a protocol for who would get it outside of a clinical trial. And as this authorization obviously is going to be in place as we wait for more information, and based on the results of trials that are ongoing, that authorization might change or not. But that's where we stand right now. But it's not like you can just prescribe remdesivir anywhere and people will get it.
Sure. Okay. Thank you. Greg, did you want to add something?
No, I think that the comment was that a lot of people had asked about remdesivir, and I know that there was at least one comment about the Lancet article, or at least one question that came up about the triple combination of interferon beta 1b, lopinavir, ritonavir, and ribavirin in the treatment of COVID. And I know that we had discussed a little bit, Sergio, your being a lot more a lot more intimately associated with some of these studies. I wondered if you wanted to share some of the discussion that we had on that.
Yeah, and I think that the Kaletra combination by itself was the first actually randomized trial, and that was a negative study. And I think that people are really walking away from that. And then when they added other drugs, and that's the Lancet study that Greg is referring to, was also considered negative. And I think that in the United States, at least, outside of the confines of trials, and they're very limited, people are really not pushing that forward anymore.
Okay. I want to make one closing comment in just a second, but check with you guys to see if you want to add anything else.
I don't have anything else to add. Just, I mean, my ongoing gratitude and admiration to all our clinicians for how they stepped up. We all stepped up to the plate and really, I mean, lived our mission and our vision of really providing value to our patients and our hospital partners. I think that there's still a lot going on in many of our places, and I think that as we move into a new phase, there'll be probably new challenges. But if there's anything that we can do from the CMO's perspective and from Sound Physicians, please utilize that COVID-19 at Sound Physicians email to send us suggestions. And I think that clearly been several weeks of intense learning and sharing, but still, I mean, so much more that we need to learn.
Thank you, Sergio. Greg?
Yeah, I too would echo the appreciation and quite honestly the leadership, and not just from our designated leaders, but really for all of our clinicians and nurses who've been ultra focused on making sure that there is been that we are again living our mission of improving quality in our communities. I think that's been by far our biggest focus. And I think not only what we've heard from you all with respect to some outstanding patient outcomes, but quite honestly, what we continue to hear from hospital partners. And so I too express my thanks and also my desire to make sure that these remain as useful to you as possible. And so we continue to seek feedback on not only the content, but the direction that we take these webinars. So I'll end there.
Thanks, Greg. Stephen, can you go forward 2 slides? I just wanted to share something that that a critical care physician said during a meeting that I had last week, which, and this picture is of a patient who was discharged from the hospital, I think in San Antonio, after 6 weeks of being on a ventilator. And so obviously everybody's cheering for a victory like this. But this critical care physician said to me that still at this point, pretty much if you come to me, you're going to die. And that struck me as a pretty hard situation to be in. And I was reflecting on the number of patients and families that have been impacted by this illness, and just thought that obviously all of you deserve incredible thanks. And also the patients and the families, including the people we haven't been able to save, deserve thanks. I know that all of you did your very best. We continue to do our very best, and we have learned from them both scientifically. We've learned a lot of compassion. A lot of things have changed for the better in the hospitals. And so I just wanted to acknowledge the patients and the families and the value that they have brought to us. And I'm sure that you feel that as well. And so thanks to all of you for learning from our patients. Please do send us an email if you have other questions, and thanks for all the great work that you're doing.